Every day, you essentially pay your dues by doing the harder thing when it's the right thing to do. All right, so first things first, are there any questions from part one? Because we did cover a lot of info. So questions first there, if anyone's got it. If not, it's all good. All right, cool. All right, so part two of this hip party. So yeah, I thought a lot about the best way to treat part two, because obviously there's a lot of stuff we could cover. I think what would make the most help, and I was talking to Dean this morning about it, is probably to cover just some basic stuff first on patterns, but then really spend a good amount of time on the hands-on objective assessment, so passive range of motion, and using that same algorithm of the layers of like kind of what layers are you trying to understand, maybe where pathology is coming or where limited range of motion is coming from. And kind of go through, I guess, mostly half the time I would say is probably on differential diagnosis of different stuff that we're going to see in the clinic. And so talk about, obviously FAI, the passive range of motion stuff, breaking that out, Craig's test, and kind of working your way out of the layers. And then FAI versus like hypermobile based people. And then obviously going through a lot of different contractile layer stuff. So different soft tissue limitations, but also pathology that you're going to see in contractile layers type stuff like that. I figured that would be the most helpful because that's clearly what we need to be the best at, is subjective and objective assessments to find the right bucket for someone to fall into. And then treatment stuff, everyone here is really knowledgeable on, basic exercise progressions and stuff like that, and I'll give you my ideas obviously, but I don't think it's really easy to make a good exercise program when you have a good diagnosis and how to modify your programs. It's really hard to make an exercise program when you kind of ish know what's going on, and then you kind of like fumble your way through an eval. So I would say that's probably the most important stuff. And then on the second part, I was thinking about treatment stuff, about what would be the most useful. And rather than just give you what I think unfortunately some courses give you or other places is just like a very broad overview of like what they might do. Like I would modify their workload and I would give them an exercise program, neuromuscular education. You're like, okay, bro, like what do you actually do when someone's 2 weeks out of a hip surgery? Like I don't know how to help this person. And they really don't, they skate around like the actual nuts and bolts of what they do. It's perfect opportunity for M.W, who is a patient for HIPAA violation, you guys know, of what I'm doing with him literally right now, 2 weeks out of post-op surgery from a labral repair and a femoral osteochondroplasty. I think that rather than go through advanced exercise progressions, which you could probably get many other ways, I think going through the very acute first 4 to 6 weeks of what someone's labral repair you do with someone on the table, it's probably more beneficial because that is terrifying for most people who have never really dealt with hips, but it's also terrifying for new students who don't know how to do anything, right? I didn't get any education at all on what to do with a post-op hip besides a total hip replacement, which was don't do these things, but the rest of it, good luck. And even now, those precautions are kind of out the window with superior approaches or more modern approaches. So I think that's kind of overwhelming, is sometimes the surgical side of the fence makes so much progress so fast in 3 to 5 years that they know what types of repairs to do, and these surgeries are happening more often, and they know what not to do for rehab, but we don't get that information given to us on the actual treatment side. So we get someone and we're like, well, I don't know, like don't do this, but like we don't know how to actually help somebody. So I printed out Mark's protocol from the physician that we're working with, who's very, very good. I will admit, this is not a knock on the physician, this is a knock on all surgery in general, is that it is a dot protocol. It's literally like dot exercises of do this, do that, which is brutal for us to follow. We'd much rather have a very step-by-step, follow this at day 2, this exercise week 3, week 4, because of the surgery they did. And so on the drive, I'm not going to go through different surgeons who we like more or less because we're all fans of them, but there's a few surgeons who are really, really big fans of their protocols because they're very in-depth, they're very specific for why they're choosing certain exercises. So the DOT protocol is not my favorite, but it is better than some of the other protocols, which are like eval and treat, progressive tolerated, which don't help at all. But we'll spend the next half going through what I would do with what I'm doing with him right now and what the next couple weeks look like, to kind of maybe give that to be a little less spooky. And then from there, we'll talk at the end about what his intermediate and advanced phases are stuff. He's a baseball player, he's a first baseman, and a very, very good hitter who has a college scholarship and possibly ML prospects. So what that rehab will look like down the road, intermediate, advanced, stuff like that. Cool? Okay, So just to kind of give you an overview of where a lot of this information comes from. So the Warwick Agreement, the Zurich Agreement, those are kind of really big position papers on intra versus extra articular pathology, as well as the Doha Agreement, which kind of looks at like inguinal groin pain and some other stuff. And so those are kind of where most of these clinical algorithms come from. I took Mike Voigt's course in 2016 or so, which was the first course that I found was really, really beneficial. He works with Dr. Bird in Tennessee, in Nashville, and so he's got a really great progression there. So I worked with his stuff online, found that really helpful, and then I just finished Mike Ryman's course last year, which was also super helpful as well. And then, what up, bro? Oh, there's one more. That's perfect. So those are really helpful. A lot of stuff comes from there. Obviously, those guys are studs with some of the research review and stuff like that. A couple really useful articles. The Weber and Calcivart ones are more on the micro instability, hypermobility side of the fence. Ryman has great articles on more the intra-articular pathology side of stuff, along with some great surgeons from Colorado. And then the Noah and the Kelly textbook that I've been referencing. Don't buy it, it's way too expensive. But it has a lot of really, really good chapters in it that if anyone is curious, I can bring them in and you guys can check them out. Because that's like a surgical consensus statement textbook on, it's from 2016 about like all the stuff they're doing for evals and stuff, and I found it really, really helpful. So that's where a lot of it comes from. Very briefly, the patterns we're going to look at. So toe touch, back bend, turning, squat, step down, lateral lunge, and a single leg, possible like jump and land, stuff like that if you look at it. But I just put these in here because it's good to conceptualize what joints are doing what, because you want to see obviously what the hip is doing. You want to see what the femoral on acetabular motion is, but then obviously in closed chain, you want to see what the acetabular on femoral motion is, right? So when you do a multi-segmental toe touch, you get anterior motion of the acetabulum on top of the femur, right? When you're on your back, you get femoral motion on top of the acetabulum, right? So anterior, posterior pelvic tilting mechanics. And then actually something that I've been picking up more from the TPI golf, from like Scududo and Lenny and stuff, is actually looking at ER, IR femoral motion as well. So for rotational athletes, being able to distinguish femoral on acetabular, IR, ER, versus acetabular on femoral motion, right? And so I think that's really helpful from the golf world. Obviously, PRI was pretty popular with getting some of those mechanics in there. And so it's kind of just taking all those systems, putting them together. But I definitely look at some of that stuff more if I have a rotational athlete, golfer, baseball player, someone who does need to change direction a lot. I do want to see, can they control, this type of pelvic motion here, but also control this as well. The same way as can they control this motion front to back along with hip flexion up and down, just because it has a different influence of how they're going to move well. So extension is the opposite. Hip extension, obviously, multi-segmental rotation is important because, as we'll talk about with the Craig's test, right? As we know from the last lecture, the capsular tautness and the contractile layer in the soft tissue stuff is different in extended versus flexion, right? So when you're standing in hip extension, right, and you're doing ER, IR, which would be the equivalent of prone ER, IR, what capsular area is more taut? Pop quiz. There's three main ligaments. Which one of those is more taut when you're hip extended? The iliofemoral ligament, right? Anterior capsule is more stretched, versus when I'm on my back or I'm in a deep squat and I'm doing ER, IR, what's probably more taut in that? Yeah, ischiofemoral posterior, right? So when we think about contractile layers, obviously think about layers. We're thinking about what layer of the hip is pathological, but we're also thinking about what layer of the hip is the reason this person can or cannot move enough or is moving too much, right? So if we put someone through an assessment and their hip extended rotation is really limited, and then we lay them on the table and we do a Craig's test, which we'll talk about, it's just an osseous femoral anteversion, retroversion test. If someone has a raging amount of anteversion in their hip, which causes them to have a different toe structure, I'm not going to give them any mobility work for that, right? I can't 90-90 stretch them out of hip IR retroversion, right? So in that conceptual mind, you say, okay, the reason this person's hip rotation is limited is an osseous change, along with maybe an x-ray of the alpha angle or camera pincher lesions and stuff like that. If they have a camera pincher lesion and they have some sort of version on a Craig's test, you should stay so far away from giving them aggressive mobility work because you're going to jack that person up, right? Versus you get someone who, negative Craig's test, perfectly normal in their range, doesn't have bony osseous changes, and has a ton of hip flexion limitation and IR limitation. that's probably soft tissue, right? That's like posterior glute soft tissue, posterior capsule stuff. I feel very comfortable mobilizing that person into stretching and stuff like that because we can probably gain some IR there, okay? So that's important to remember of prone versus seated or hip flexed. And then obviously squatting, step down, lateral lunge, that stuff is gonna tell you how these joints are moving together for hip, knee, ankle, but also it's actually a really good way to do diagnostics as well, which I got from Mike Ryman's course, which is being able to, can you cue somebody in or out of symptom modification, right? So say somebody, you have no information about their x-rays or anything, but if they squat narrow with their toes straight ahead, they feel some FAI symptoms, but if they turn out 15 degrees and widen out just a little bit, their symptoms resolve quite a bit. That's a good idea that one, you have something to work on right away, but two is maybe there's a way to work our way around this versus, you know, rushing off to having some imaging done right away. But also too with, you look at the research on trunk pitching in lunging and also in rear foot versus front foot elevated back squats, which we talked about, right? Cueing someone, if someone really leans really far forward in a front squat, or sorry, in a front lunge, right? And they put a lot of anterior pelvic tilt on the front of their hip. It could be that maybe they just don't know how to split squat properly. Maybe they need a more upright torso with dumbbells versus front racking their kettlebells. I don't know. But position of trunk, right, will make a big difference on that as well. So we like to look at squat, step down, all that kind of stuff from a movement quality point of view, from a symptom point of view, but also can we do different things or cue different things to change their symptoms or stuff like that. It also comes up quite a bit in the back of the hip. When you have someone who has maybe proximal hamstring tendinopathy or adductor strains, and they do a squat, for example, but if they squat to 45 or parallel, they have no symptoms at all. But when they lunge, because it puts their leg into more hip flexion on the front leg, they get more symptoms. So in your head, you're like, all right, what are the patterns I'm going to try to load? Squat, hinge, split pelvis, single leg accessory. I'm probably not going to load a deep squat. Maybe I'll go to a box squat. I'm probably not going to load a really deep lunge, but maybe I can get away with a low box step up because they're not going to be putting themselves in a really high flexion angle. And then maybe I can get away with some sort of a bridging modification that puts more load on their glute than their hamstring, right? So in your mind, you're watching somebody move, and you're obviously looking for symptoms and stuff, but also as you work your way farther down the eval, and you're thinking about, well, what does the table assessment tell me in relation to movement assessment is, well, what am I going to load them for? What patterns are available for us to load, because those are going to be really, really helpful to start somebody with. But also, you want to educate somebody on what they're modifying. Like, they can still work out, just squat to a box, or they can still do lunges, let's just do them on a split squat to 2 ARX pads with more load versus range of motion, okay? And then lateral lunges typically come into play with adductor pathology is really what you're looking at, right? Obviously, the lead side is going to be compressive, so maybe you will sneak some FAI symptoms there, but the trail leg is going to be very much eccentric overload to the medial adductors. So you might have someone who has pathology only with a couple tests that show up on certain squatting and lunging and stuff like that. I don't feel as though we need to go through the movement assessments and break down joint by joint. I don't think that's very helpful. Does anybody else feel like they need that? If not, it's totally fine. We can talk about it after, but I feel like the better use of our time is the table stuff. Okay, so let's just cover some background stuff on passive range of motion, and then we'll talk about Craig's test. So this is the first layer that we're pretty much, the osseous and osteochondral layer is really, it's not the only thing that's going to limit passive range of motion, but it's the first thing in our mind of what we want to make sure is not a problem, like I said, for the stretching versus not stretching situation. So on the FAI side of things, the things you want to have from your subjective evaluation or your background knowledge is, right, is you're thinking about, does this person have a high alpha angle, right? 60, it's going to be that femoral sided lesion we might think about as an overgrown cam. Does that person have a tonus angle or something, or a lateral center edge angle that is extended beyond that, because you might have someone with a pincher lesion, right? Or they have a mixed, or do they have a history of, they know they have, they sat in a W as a kid and they have a significant amount of anteversion or something like that, or retroversion. So you want to have that stuff in the background to know. And then also, the main things that we're going to be thinking about in terms of limited motion and symptoms is probably limited IR and flexion, right? That's a pretty classic scour. There is mixed literature on whether the cam itself is the reason the motion is limited. There was a really big study in football players that Mike Ryman had a really good presentation on, looking at, I believe they measured the people with limited IR, then x-rayed them or MRI'd them to see who had femur lesions for cams, and then those who had symptoms went on to have surgery, and they retested their range of motion to see where that motion was coming from gaining-wise. And a lot of the people who increased motion, it wasn't because of the cam. It wasn't like the cam removed caused this huge swing in IR. For some it did, for some it didn't, So I think what it tells you is that it's not always that somebody will get this massive swing in IR because they have their cam removed or their pincher removed, but their symptoms may be significantly modified in that IR and compressive position, and that's really what you're going for. So, and the reason that is because think about last week, we talked about all the things in that space that are there, but also the variability in osseous morphology in the hip is so much more like we talked about in the shoulder. So you can have somebody with femoral anteversion, retroversion, you can have somebody with acetabular anteversion or retroversion, acetabular tilting, overcoverage, undercoverage, there's neck inclination. There's so many things that can influence somebody having or not having motion that if you just scrape the cam down, it doesn't always mean it's going to improve. But if they do get a little bit of motion and their symptoms go away, and that's the case that actually is happening with the baseball kid right now, it's just our first couple bouts of motion. He's like, whoa, this feels completely different in terms of like nervousness, compression. I mean, we're only up to 70 to 90 degrees of hip flexion, so we don't really know, and I haven't done that much IR, but already he's off to a better start because of that. So that's what you're looking for on the don't have enough mobility or passive range of motion side of the fence versus dysplasia, which is the complete opposite side of the fence, which is somebody who has a tonus angle that's really low, a lateral center edge angle that's really low. They might have a posterior wall sign. Right, all those signs that tell you that they have undercoverage, okay? And what that is going to be thinking about is that when you look at passive range of motion, is you're looking for the presence of excessive range of motion, right, with symptoms, just like the FAI, right? Limited motion with symptoms is FAI. Excessive range of motion with symptoms that matches the pattern of that fulcrum or tipping mechanism that we talked about last week. Just to review, which is the concept of femoral neck sits here. Say if somebody extends their hip backwards and they make contact with the posterior lateral wall because they're going so extended into that range of motion, gymnast, dancer, circus artist, explosive sprinting athlete who's got a really large sprinting stride, if they tip back and they hit the posterior lateral wall of the femoral neck, they could possibly make contact and anteriorly tip out the front. Okay? So what we're looking for in apprehension signs is to reproduce that impingement tipping mechanism, which most of the times, because the athletes are so hypermobile, they're going to feel apprehension and instability on that motion you're going to. They may sometimes feel symptoms on the contact. So I have had people, particularly the higher level athletes that I work with, so very high level gymnasts, very high level dancers or cheerleaders, they do feel symptoms in the back outside of their butt area because that's where the bone is being impinged, but most of their symptoms are anterior medially with that tipping phenomenon. So the tests that we look at with dysplasia as the special test part are really looking to try to reproduce that apprehension and that other side of joint pain, just like you would in an overhead athlete. You're looking for anterior apprehension, right, when you put someone in layback because the glenoid is now being pressed on as it comes forward with the humeral head. So make sense with that? Cool. Kind of, I mean, we're putting them in two big buckets of you don't have enough passive range of motion or you have too much passive range of motion, but for the sense of argument, we'll kind of just leave it there. So first thing we'll look at is a Craig's test. So Craig's test is essentially a really good table way to get an idea of does somebody have more anteversion or more retroversion from the femur point of view, okay? And I'll kind of just do the picture here to make sense, but 8 to 15 is normal because remember from the acetabular plane, that's normal amount. The 45-degree tip of the acetabulum and that normal inclination angle is somewhere between 8 to 15 resting. So just think about it like this. So think about, I'll use my toe as an example. So say I fit normally in the joint, right? When my middle of my femur is aligned with my acetabulum, my toes are relatively straight ahead. That's that 8 to 15 degree swing, okay? Think about what would happen if I was born with a lot of forward motion this way, right? So I warped quite a bit more, right? As a compensation mechanism, I have to get back, so I would toe in to make neutral be there, right? So that person has a lot of anteversion, right? The femur is anteverted forward to make sure I don't walk with my femur constantly rubbing the front of my hip joint. I have to toe in slightly more to get neutral centration of the femoral head. Yeah, make sense? So what this means is this person is probably gonna feel more comfortable squatting with their toes more normal, right? Or sorry, straight ahead, more narrow, and slightly maybe more playing with the angle inward or outward a little bit, right? Because in order for them to squat and get proper hip flexion, their toe has to be more relatively straight forward ahead. Yeah? So what we would see on a Craig's test, right, is if you see that someone who's more pigeon toes, that person will have more IR, right? They're gonna have a lot more IR on the table because of that compensation mechanism. Good? Yeah. This is confusing, and I saw Grace's eye is like, and I didn't know this for like 3 years. So yes, more anteversion, tipping inward, toe in. What's that?
So wouldn't they feel more comfortable being toed out with the squat than being toed in, even though that's the compensation, just because that's their resting position, where they're having to almost fight it?
I think the thought process is that they like more neutral because their hip is resting normal there, right? So think about if that person was really anteverted, toed into a middle because they're neutral, if that person toed out a lot, they're going to be sitting anterior in the joint, right?
Okay.
So my normal resting hip from birth is front, right? I compensate by pulling back into neutral, right? If I were to toe out a ton, I'd be putting a lot of stress on the front of my joint. It doesn't feel awesome because I'm not in the middle of my hip joint,
Okay.
right?
But would their resting position, wouldn't that be toed out a little bit?
The resting position would probably be more neutral because they're trying to compensate for the femur being forward.
Oh, okay. So you're saying because of that compensation over time, that becomes
Right, right, because their growth plate's probably closed with it forward, and so they've come back a little bit to make it feel like it's in the middle more. I could be explaining this wrong, but I think I am. We're good? Does that make sense?
That makes sense. I just would have thought that because the growth plate closed that way, they'd almost most comfortable resting in that position rather than having to toe in.
Yeah, they probably grew up sitting neutral, so foot more straight ahead to compensate for that, because most people have a degree of toe out as they grow up because tibial ER as well, so they probably want to be more neutral, okay? And it might make sense when you explain the other one too. So think about the opposite of this. This person grows up with a lot of backwards, right? So retroversion, right? This is going to be someone who's going to eventually become a dancer or a cheerleader because they have good toe out, right? If they're back in the joint, they compensate for more toe out to get to neutral, right? So this is a person who, if you put them in neutral, they feel terrible. Because what happens is now you're back, right, and they want to turn out. Dan's a really good example of this. If I were to toe them in more, I'd be very far in the back of the hip joint, right? So now when I try to squat, I'm not anywhere close to neutral in the hip joint, right? So that's going to be someone who probably doesn't feel awesome with toes straight ahead or a narrow footprint. And Dan's like that. When Dan squats, he literally has to squat like this, very narrow, very toed out, because toe out makes him feel awesome. If he becomes in a little bit, he feels horrible, right? And I think there's a lot of good examples of that. And there's always variability, right? Because we don't know what the acetabular position is with the Craig's test. But in this person, you're going to see someone who has a ton of external rotation because they have so much space to work with. And that's why gymnasts, cheerleaders, dancers, ballet dancers in particular, they're naturally selected towards this because they have natural retroversion of their hip that allows them to toe out. So when they stand like this, they have no symptoms at all, right? Other people who are not blessed with the right parents, they try to force this as they're a young kid, and it blows their hips up because it hurts so bad. Not to mention those people who can toe out a lot are probably also very dysplastic. So they can do these crazy things with their hips naturally. I am one of those people. I was blessed with very flexible hips. That's why when I was like 6 in gymnastics, I could do splits. They were like, you should try team, right? I'm 5'6". They weren't like, you should play basketball, right? I got naturally selected into the hypermobile hip sport. So I'll show the Craig's test now, but are there questions on conceptually what we're looking at? Because I think if you can just grasp this, the rest of the stuff is really easy.
So the Craig's test in open chain will show like where they would sit if they weren't compensating.
Correct.
Right. So it's a closed chain compensation.
Right.
Do you think there are like growth plate changes that they adapt a little bit to that new position?
Yeah, I was talking to Leah, I think, about this the other day, is in the shoulder, because of ultrasound technology and because of baseball wanting to look a lot at retroversion, there's so much study that shows the natural bony retroversion from throwing. I believe that if we had the technology and the ability, and I've talked to a couple physicians from MGH about doing this study, is I think if we could get kids from age 6 to age 14 and every year do an ultrasound of their growth plates in gymnastics or cheerleading or dance or even like sprinting, rotational sport athletes, I don't know what we would find. In the ballet people and dancers, you would see that ER show up more and more, and I bet the growth plate would close that way, which is why a lot of gymnasts, if they maintain their soft tissue flexibility, can just do splits all the times, like when they're like in college and beyond, even though when the growth plate's closed, because they've adapted to that stress. In the same way that Lenny and Mike can go out and play catch because they have retroversion, I would die, right? I would blow my shoulder up if I tried to play catch with those guys because I don't have retroversion. So yes, I do think that there are bony changes to the growth plate that happen with certain sports. I just don't think we have the imaging to know it just yet. Yeah. So yes, I will show you this test. Let's actually, can you help me turn this table just so the camera can see, just for this one? And then Aaliyah, if you want to hop up. And then what we're doing with the Craig's test is let's go straight towards the camera. Yeah, we're trying to see if someone's resting bony position is within that 8 to 15 or if it's not. So go on your stomach, Aaliyah. And the way we do this is you're going to bend the person's knee up, right? Sorry, I'll do this side to make it easier. You bend the person's knee up and you want to try to palpate the greater troch, right? Where it comes most prominent to the outside, right? Which is theoretically the midpoint of their hip resting, right? So if I go like this and I palpate her greater troch, if I go all the way into IR, I don't feel her greater troch. If I come all the way into ER, I don't feel her greater troch. But if I come right in the middle for her, I feel it most prominently right there. Okay, so I try to not look and bias that, but then looking at that, I mean, Dean, you got the best angle. What would you call that IR? It's probably like 10?
Probably about 8 to 10.
Yeah, 8 to 10, so it's normal, right? So she has a normal Craig's test, right? If I go into a Craig's test and someone has a ton of IR to resting neutral, right? You're like, oh, wait a minute, that person might have a version, exactly, right? And if someone comes all the way to neutral here and they're like, I just like how Grace just instantly threw shade. Like, if she came all the way to here and like she was neutral, right? That would be outside of the 8 as well. And again, you don't change everything, but you're thinking about this person's resting anti-version or retroversion might be part of this equation to think about. Okay? And we'll go through a whole bunch of tests, and then we'll have you guys try them together versus, having to come back and forth 40 times. So yeah, that's what I do. I go on the outside. I honestly close my eyes sometimes, and I go like this, and I think neutral is probably right here for her, and that looks pretty good. And then I would come on this side. I always run like that when I do a valve. I would go right there for that one. So slightly more, but I'm definitely not shaking a stick at that, right? You'll see people who are like wildly externally rotated. And Lenny's a crazy example too. Lenny has a ridiculous amount of ER, like 90 plus. You're good. But he has like no IR. So I don't think, and his Craig's test was negative when we took a course together, but for future reference. Okay, Craig's test, and then let's go through all the layers and stuff like that, and then talk about special tests for osteochondral, and then we'll break up and we'll do more of it. We'll get back together, but yes. All right, so next, that's going to be the first layer. When we're looking at capsular assessments, right, we talked about how you can't do capsular assessments for the hip, right? I don't trust myself to glide the hip joint and be like, that's an appreciable amount of motion, like I can do at the shoulder. So the things that we can use are a Biten's test, which we all know, right? Hyperlaxity test. More than a 5 out of 9, like I said, is correlated with more hip capsule laxity under anesthesia when they distracted people. So the other thing you can do is a log roll test. A log roll test is a way we mobilize somebody after surgery to help their hip move without compressing the front of the tissue because we're in extension. But it's also really helpful to see if somebody has excessive laxity of the anterior capsule, right? Because if somebody has a ton of hip extended ER, right, they have a lot of probable laxity in the front of the hip joint, right? Because that ER is what allows that capsule to stretch out a little bit. So, Aaliyah, come on back up. Hop on your back. Yep, so feet would be facing this way. So I have her, and I'm not going to stand directly in front of it for the camera, but we're going to have her go up this way. You put her into max IR, and then you let go, and you see if she flops out, right? And I'll show you on me, I have excessively more on one hip. But what would happen is a positive test would be if this came out and say her right leg flopped out like a ton, right? More than 20 degrees between sides is what most studies show, but more than 45 degrees as well. You would think that the anterior capsule on this side has been stretched out over time, right? Think about that right-handed hitter who swings really hard all the way on one side. Think about the gymnast, the dancer, the ballet person, the sprinter who is really explosive off both sides. Maybe both capsules are really lax. But when they come out like this, you would see this big differential, and you would think that maybe the anterior capsule is more lax, okay? Hop on up for a sec. You're good. So I'll show you on mine. So this is hard to fake because obviously I can't push myself, but when I go like this, right, if I completely relax, can you guys see which side is more? Right, see how my right foot is like well beyond? I'm not trying at all, right? And if somebody pushed me more, I could probably get equally on both, but my right side of my hip is significantly more lax from gymnastics. And I have, when I squat, actually, it's interesting, I have a tough time getting into my left hip. Right, like it's really hard for me to shift into my left hip all the way. I always feel like more pressure. I've had right-sided meniscus issues because of that and knee pain, and I think it's because my right hip is significantly more mobile from doing all of my splits on one side and doing all of my stretching on one side for gymnastics. I was a righty round-offer, right, for tumbling. So this hip has gotten substantially more lax over the years. I also have a much stiffer left side posterior chain. So when you do splits in gymnastics, my left leg in front, my right leg in back, the right side of the front of my hip capsule got stretched out a ton because I'm so tight on the left side. I have no idea why. But my hamstrings have always been stiffer on the left side, so I stretch out this capsule quite a bit more over 20 years. And so I feel that quite a bit when I do motion and stuff like that. So for me, gymnastics, you're probably not going to treat a male gymnast in your life, but the rotational hitters, I think, are a big part here, and also rotational athletes in general, pitchers for sure, because you think about coming over the top and pushing so much out of your back leg. I think it does make a difference. And then obviously you have lead leg IR that happens a lot more in that sport. So that's another test you can do to just kind of get an idea and extrapolate around who maybe is more loose or more tight. The hip extension external rotation test, the HER test, is like the Thomas test, but it's a way that we look at excessive motion for somebody who might have, again, anterior capsule laxity. So Aaliyah, come on up. Let's turn this sideways. Boop. So here, let's have you sit on the edge like you're doing a Thomas test, right? And so think about the motions that stress the anterior capsule, right? So hip extension and hip ER. So if we have her hug her knee and lay back, and then when I try to push her down, if she were resting like this, was really, really low beyond the table, just resting naturally, that person has a lot of anterior capsule motion to get down that far. And then it's a test for instability, but if I went like this into ER and I could push her really far into hip extension and ER, and she started to maybe have symptoms in the front, you're not thinking about like, compressing that tissue, it's stretching the crap out of that tissue. So this is telling you that someone has a lot of laxity possibly in the front of their hip. You're good, you can sit up. Right, so those are just things in your mind. If someone doesn't have passive range of motion, when we do our table assessments, and then you think about, Craig's test, osseous changes, radiology changes, and they're limited in motion, and they have compression symptoms, you're thinking in the not enough motion kind of has an FAI type symptom pathology, versus someone on the other side of the fence is log roll test is positive, tonus angles are low, lateral center edge angle is crazy low, right? And they have, like they do a Thomas and they flop off the table completely. You're gliding the femur forward when you do a Thomas test like that, right? If they sit on the end of the table and you push like that, you're fulcruming forward. So you're having someone drop really, really far off the table. And those in your mind are the ideas about, okay, is this the really, really move too much bucket or the doesn't really move enough bucket? All right? Okay, so this is where actual passive range of motion stuff will come into more placement. So we're going to do hip flexion. We're going to do hip flexed ER, IR, right, with the Craigs in the back of our mind. We'll do a Faber and break that out, and then we'll do some hip extended IR, ER to look at the different stuff. And then we'll probably go through and do those all on each other just to make sure we feel cool. Thomas, I think we all get that. Strength, also we kind of get that. We'll talk about some position work. But yeah, the first four are really more important. So, all right. It's your moment to shine, Aaliyah. All right, on your back, I'm going to awkwardly do this over the table. I would obviously stand on that side probably, but I'll do this side so that you guys can see and not be blocked. So first thing to think about is acetabular plane, right? So when we range the shoulder, right, and we do scaption, we all do scaption in like the 20-degree plane, right? We don't really ever do flexion like this, right? I would never range someone's flexion like this. Why would you not range someone's flexion like this to get assessment? Yeah, it feels terrible, right? And it's really not sport specific or life specific. No one's like getting their dishes like this at home, right? Same thing with this. I think automatically in school we were all taught or we did stuff really, really neutral to the plane. But what is this doing when I'm really neutral and I'm going all the way up? What's the equivalent of this? Yeah, like a mega narrow squat. Like would you ever ask someone to be like, all right, let's see what your squat looks like, right? As a party trick, but that's essentially what's happening is you're doing a lot of adduction. You're putting a lot of possible femoral neck compression there. So when we range people, we really want to appreciate what acetabular plane feels like with a little bit more abduction and a little bit of ER, right? You never want to range someone in IR narrow because that would feel terrible. So I think when I range people, I'm automatically going to slightly more ER and slightly more abducted just for their normal plane of motion, right? And then you can play around with, all right, like what if we change your squat stance? Or like what if we did more ER way out here? But for now, if I'm just looking at what somebody has, I'm trying to look at what they have, one, when I start to feel a lot of motion stop, but also when you start to see a posterior pelvic tilt, right? Someone's available range of motion is going to be probably to here, and then I think she starts to really like, you see her hips kind of roll back a little bit. So that's kind of in me, I would say probably like 110 right there, right? We'd actually go in it and stuff like that. But I think looking at that in the right plane is really, really important. Also, when I do exercise, stuff like that, I'm trying to figure out how to get that person comfortable with width of this way, right? So squat will change that. The other thing you can do is a quadruped rock back test, which I think I learned from Aaron from Squat University early on, but it's a good way to kind of also see when somebody might round under that way. So let's go hands and knees and put your feet about hip width apart as if it would normally be, and try to think about rocking backwards and maintaining a flat back, and then just go as far as you can, right? So she's pretty good down to there, right? So say somebody, for example, go really narrow to make an exaggeration here with your feet, yeah. So say she comes in and she comes all the way back up to hands and knees. So say when she rocks backwards, if she has her feet really narrow and she's squatting really narrow, try to rock back, you'll probably start to see an earlier round of their back here, right? Versus if you have them come back up, bring your feet hip width apart a little bit more. If we change their squat stance out and they can get all the way back by maintaining a proper neutral curve, you could say that's probably going to be a better squat position for that person, right? So you can play with width of knees and turnout of knees in a quadruped rock back and see if somebody changes their symptoms or if somebody is able to maintain a neutral curve all the way down, right? If they have FAI symptoms or have morphology changes, and if they rock back, and as soon as they get to like 45 degrees of hip flexion, they tuck under, and they get a little rounding, you think that person's going to probably wink or have FAI symptoms more so. The other thing you can play around with too, that we don't have to do, but you can play with anterior and posterior pelvic tilt, right? If someone really doesn't understand how to control their spine, and they're mega arched when they do a quad rock back, that's the equivalent of trying to squat and having early symptoms probably here. So if you teach that person to cue a little bit and drive their hips back, it might modify their symptoms a little bit, okay? So that one's really good. And then hip flexed ER, IR. Okay, so same kind of idea is make sure they are in the plane out a little bit there, get to ER neutral, and then I'm seeing from here, if I maintain this, how much ER do they have this way? So I'd say she's probably like 45 to 50, and then here as well, I'm trying to do IR and try to maintain over, right? I don't want to IR her down here, because that's not going to give me an appreciation of femoral neck on acetabulum symptoms. So here, and just IR, she's got about 25 to 30, which is pretty good, right? And I also see from my side, you can't see it, but when I get to here, she starts to kind of like laterally tip her pelvis a little bit. Maybe I can show it over here. So if I did this, right there, so like last little bit. So that's kind of the end of her motion there, right? I got to probably crank her 5 degrees more, but I think that's probably her available motion this way. And then same thing here. Her hip starts to move at the very, very end, or her pelvis starts to shift a little bit. So hip flexed ER and IR, the way to do that. And then Faber, we might as well do while we're here. So Faber tests, I think, are definitely used as a special test to diagnose hip pathology. There's pretty good literature for that, but also Faber's can be very useful as a passive range of motion diagnostic. And we've talked a lot about this in other mini lectures, but just to cover it. So Faber, right, is the flexion component, the ER component, and then the abduction component, right? And if somebody has a lot of hip flexion and they have a lot of hip ER, right, and someone still has a very, very positive Faber, which is supposed to be, you know, I think the rule of thumb is about 6 inches or a thumb up like this. So she has a positive Faber, particularly if I'm being strict here. She has a positive Faber, right, but she has more than enough hip flexion, and she has more than enough hip ER to get down there. So what other two components of that test could we break out and probably try to look at? Adductor mobility, and then you could also argue that hip extension mobility, right? Because the ability to drop into the Faber position requires hip flexor and quad end, right? So the adductor stuff, and this is maybe more my theory from all that I've read, and I think the surgeons I've talked to agree with this, but when somebody drops into a Faber, right, like the anterior adductors are also being quite a bit stretched. Remember what the anterior adductors do. So pectineus, brevis, and part of longus is hip flexion from a position of extension. So that initial pull through, right, that's a lot of sprinting people, a lot of rotational athletes. The anterior adductors can get really, really stiff and then limit the Faber. And that could be an indication to you that anterior soft tissue and that some of the stuff to work on is adductors, right? Along with, we'll test Thomas. We already know from hers it's not positive, right? So for me, in my mind, I'm thinking that the anterior adductors might be a reason why her Faber is limited, and that might be contributing to some of her symptoms. The other thing that can change it is pelvic position and core position, right? So if somebody has a very anterior pelvic tilt, right, that's going to take the acetabulum, put it over the front of the femur, and it will limit external rotation into that dropout Faber position. So if I change the position of the pelvis and the Faber gets drastically better, right, you could argue that's probably a core position issue and not a true mobility issue, right, of the hip, right? So that's someone who maybe doesn't understand how to get a proper neutral brace. Versus, again, my theory, if I Faber somebody and it's limited, and then I posteriorly pelvically tilt someone and it gets substantially worse, right? I'm thinking that I have just taken the proximal ends of all the adductors and I've pulled them farther away from where the leg is trying to go. So I kind of in my head might further rule in soft tissue mobility problems. This is pending the person doesn't have osteochondral fragments in their hip joint. very important. But like, yeah, that obviously would limit someone's motion if you had giant bone spurs. But if that's not the case, so if I do a Faber and I have her show here, right? So I know it's not the extension component, and I know it's not maybe the adductors. We can test other ones with another slide out test. But if I have her put her hands up, right, and I have her push into the back of my shoulder, it'll posteriorly, push forward, Leah. Yeah, it'll posteriorly tilt her more, and I don't see a lot of change at all. It didn't get better, it didn't get worse, right? So I don't think position of core is something that's the big deal. It's probably anterior adductors and possibly middle adductors, which is what we'll test out next, okay? Again, if she did that, right, if she pushed down and this dramatically flopped down, we would know that's probably core. And if she pushed down again and it went like this really far up, I'm thinking that I'm tucking her hips under and pulling the proximal attachments of her adductors and her, arguably her psoas and stuff like that closer, right? So it's pulling more time away. So in my head, I'm thinking like, is it a core thing? Is it a soft tissue thing? Or is it like a true limitation somehow? Yeah? Questions on that? Yes.
Sorry, just to clarify.
Yep.
You're saying in a posterior pelvic tilt, when you're saying soft tissue is a limitation,
Yep.
that's the adductors, correct?
The thought process, yeah.
Okay.
Because a lot of the high adductors in the front are attaching like up on the pubic rami in the front part of the pelvis. So if you were to take that front part of the pelvis and pull it farther away from where the leg's trying to go, you would think that maybe soft tissue is the issue.
Because hers didn't change at all, like it didn't worsen with that brace,
Mm-hmm.
does that mean that it's still adductors, or are you thinking more?
I would think yes, because to my knowledge, she doesn't have cartilage popping around in her hip joint.
Yeah.
Nothing changed with the pelvis, right? And she has enough hip extension, which I would test that after to see, but I know she has hip extension. So she can't get her Faber down. And it's not the hip extension part of it, and it's not the core part of it. So we're probably left with the anterior adductors. Yeah. And you can test the medial adductors as well, which is the next piece of this, which is the hooked abduction test. So shimmy this way, drop your knee off the table here, and then from here, I would do this way. She does not have limitations in her medial adductors, right? She has like 85 degrees of abduction. So you can put these back up. I think 60 is normal. I think this is from the soccer literature when they started looking at groin strains. They were looking at if mobility eccentrically was an issue, so they looked at this test. I think strength is more predictive of that. But she has plenty of adductor mobility that way, right? And you even could argue she has plenty of adductor magnus and hamstring mobility because she can squat. She can pull her hip up that way. And she doesn't have quad or hip flexor limitations, maybe a little TFL, but the only thing left to limit that soft tissue-wise is probably the anterior adductors. And it does make sense because most people don't do anything for their adductors in general in terms of soft tissue stuff, proper mobilizations, eccentric loading. So most people I find have a lot of adductor mobility issues. Most people are good at stretching their quads and doing their hip flexor stuff, but not really as much on the anterior adductor piece. Okay? Don't go anywhere.
So, when you just looked at her passive abduction and it was normal,
Mm-hmm.
how do you assess, or is it just process of elimination, the anterior adductors?
Yes, because the thought process that the fibers can anteriorly can pull you from extension to flexion, which would obviously be limited, right, if you had the extension ER component. And then medial adductors are kind of a separate division that also limit. And then the magnus is particularly only for that deep hip flexion, that hip extension from a position of flexion. So if I'm looking at if magnus is an issue, I do squatting, lunging, and passive hip flexion to see if it's limited, along with the hip joint itself. If I'm doing the fallout one, it's mostly like longus gracilis and some of the fibers of magnus, you could argue too. But the anterior adductors really aren't stretched that much, limiting extreme abduction that way. Whereas the Faber being really limited, and I know she's a lax individual, it's probably soft tissue. And if she doesn't have hip joint pathology, like a chondral lesion or FAI, you're like in your head, yeah, what's left on the table to limit this, right? The core maybe, nope, it wasn't that. Or the ER component, the abduction component, those both could be limited a little bit by the anterior adductors. Yeah, again, more theory from research that I've read, not like hard and fast science like a cam lesion, but I've seen that to be pretty helpful accurately.
And would you like foam roll or like?
Yeah, so anterior adductor soft tissue work, we'll just cover it now. So if someone has anterior adductor stuff, I like to do rear foot elevated split squat eccentrics because it puts a lot of hip extension. If somebody has medial adductor stuff, I usually do more, oh my God, what's that thing I'm thinking? Slider. Yeah. A slider eccentric out to the side in like a frog position. And then if somebody has limited adductor magnus, I'd be doing more Cossack squats to get them post back into their hip, like lateral Cossack squats back this way. Yep. And then stretching wise, the half kneeling adductor dips half kneeling rocks to the 45 are typically going to get anterior medial adductors, whereas the half kneeling rock back is probably going to get more the posterior magnus fibers because you're pushing yourself back. So I differentiate a little bit between, split squat versus the frog stretch eccentric versus the Cossack squat based on the anterior, middle, or the posterior adductors being limited, right? And that would be the equivalent of hip extension is limited, hip abduction is limited, hip flexion is limited. Yep.
So you said half kneeling and then half kneeling 45 for like the...
Yeah, the half kneeling 45 degree like adductor dips, I think we call them, is usually more on the trail side you get more medial stuff. Or sorry, the trail side you get more anterior medial stuff, whereas the lead leg you also get some pretty good adductor magnus type stuff like that. So I usually do that for someone who has some stiffness in the front with like a positive favor. I'd be giving her those like really posteriorly tilted, really rocking sideways, right? And then someone who has limited straight medial adductors, I would just do like a one-legged slider eccentric stretch. Someone who's limited in posterior magnus, I'd be doing rock backs, one-legged adductor rock backs, because that definitely gets more the posterior aspect. And then go on your stomach with that. So yeah, if the Kreg's is on your radar of what you're just doing literally prone ER, IR to check if there's a differential between hip extended mobility versus hip flexed mobility based on their sport or based on their activities. Do they want to squat, Olympic lift, just be healthy and fit and pick their kids up, or do they want to do sports that require explosive rotational movement? So you would just do the same kind of deal, put them here, hold their hip, and go max IR, right, and then max ER. And you would just kind of get appreciation and motion of that, and you can obviously measure from the bottom down that way. But yeah, obviously the differences are important. I wouldn't go too crazy on like reading into, what they mean if somebody has more or less on one side versus the other, because there's so much variation again in the pelvis osseous structures. But I do like to see, one, that they have motion available for their sport, but two, that there's not like one dramatically painful or limited IR, ER swing or something like that. And that's the biggest thing, is really like hip flexion, ER, IR, the Faber test, the hip extended stuff, the Thomas test we already did, right, which would just be the same exact thing, but I'm just looking to see if it's limited, not cranking her into more extension. I would just let her leg drop, but she had no quad stiffness, she had no hip flexor stiffness, she had a slight lateral drift, but again, I think that's more the plane of the acetabulum probably puts you out a little bit. She doesn't have like excessive TFL stiffness that way. All right, so let's pause there and do like on each other. Just go quickly, just get that through your system. Then we'll come back and do a special test. So 5 minutes to just like break that out with a partner real fast. And also too, it's good to note that somebody with a lot of like a very positive Thomas test, the prone ER, IR assessments will be a little bit more, limited, probably because they're in a big anterior pelvic tilt. They can't open their hips up fully. We'll go special tests, FAI, and instability. And then we'll practice those, and then we'll go contractile. Only the tests that are relevant. I don't think we need to all practice hamstring MMTs for tendinopathy, but just the ones that are meaningful there. 15 minutes, and then we'll talk about MW, his program, for the last 15 minutes. Okay, because these are the ones that are probably the most important, right? So there's a lot of tests you can do to look at FAI or compression, but in the textbooks that I've looked at with the surgeons, when they do their impingement tests, they have somebody lay on their back and hug the opposite knee to put the pelvis in neutral, which is something I didn't learn about. So I want to show you that. So test for FAI, right? Anterior rim impingement is the classic Fader test, right? Or what they call a dynamic internal rotation impingement test, a DIRI test, okay? So that's going to be looking at scouring the slap area, the anterior medial neck, okay? Not as common, but something they also do is the same kind of idea, but for the posterior rim. So if someone does weirdly have a posterior labral tear, falls on their knee, I can't think of a ton of people who can have experience with that had posterior labral tears, but you would essentially be now scouring the back side of the joint, similar to how you could scour the front in a slap tear or grind test, and then you can scour the back. You could do the same kind of ideal, right? So the dynamic IR test, you'll move from the ER abduction into IR, whereas the posterior rim, you'd kind of start neutral and IR and scour in the back as you come around a little bit. So I'll show you those. This is from Reinman's course, which is really helpful if you look at the literature. The moving Thomas test for symptoms of mechanical symptoms or pain or clicking or catching was a little bit more supportive in terms of like labral tear ruling in. So that's a good test that I've used. And then obviously in the Warwick agreement, hip pain, clicking, catching, or giving way is one of their big clinical symptoms for someone who probably has FAI. That's symptomatic. Radiology findings. And then obviously the movement patterns like we were talking about changing with symptoms. But the three main tests along with subjectives that I use to figure out if somebody maybe has that dynamic FAI is the scour or fader, the Deary, and then the moving symptomatic labral tear test, like the Thomas test. So, Aaliyah, because Kevin will hurt if we do it. Okay? So when they do these tests, in the textbooks, they have the person hug this knee to neutral, right, to set their pelvis in neutral. So here, right, if I did a IR test, I'd go from ER and abduction, and I would kind of lightly push and move her into IR and scour the anterior medial part of the room. You okay? Yeah. Does that hurt?
A little bit.
Yeah, okay, positive. So I'm not going to push hard, but I'd go here and I'd go into IR, and that's the Deary test, the dynamic internal rotation, right? Impingement. So you're dynamically putting someone into IR as they do it, right? The scour test is very similar, just with the leg out. You cross them across midline, and you do IR, and you would push to see if they have symptoms. Okay? And then the moving Thomas test, sit on the edge again, is now she would hug this knee, right? And I would have her lay back, and then you're bending this knee up, and you're essentially moving someone through dynamic hip extension in midline where you would test the Thomas. And if somebody had clicking or catching or pain or felt like, ooh, like kind of caught them a little bit, you would think that, the theory being, is that as you move someone from that flex position and you come down the inside of the joint, you might be rubbing against the anterior medial part of the slap lesion that might be a labral tear or something like that. So if somebody has pain and clicking and catching and popping when they kind of go through that mid-range of motion, you might think that also is indicative of someone who's symptomatic with their FAI or labral tears, right? Whereas this is probably more the labrum versus the actual scour Deary is probably more the dynamic FAI of the femoral neck or the cam lesion on the wall, okay? So that's going to be the main three for FAI, and we'll check those out. Okay, for the other side, which is the person who moves too much and has apprehension, right? The ones that they use are the log roll, right? The here we talked about, the hip extension overpressure test, and then side lying and prone instability ones have some decent support for them too. So let's go on your side facing that way. So we'd be thinking in this person, right-sided anterior hip pain from excessive motion instability, right? The way we do this is hug your bottom leg a little bit, okay? And now think about the mechanism, right? This is running on your side, right? So if I'm sprinting behind me or I'm hitting behind me, as her right leg comes back and externally rotates, I might either impinge the posterior lateral wall and cause anterior migration of the femoral head, which pushes on the slap, pushes on the iliofemoral ligament, pushes on some of the anterior capsule, or I could just have symptomatic soreness because that femoral head's trying to go forward, and maybe the hip flexor is getting a peritendinitis because it's trying to hold the femur back in place, or the rectus femoris is also getting blown up, or the capsular tissue or the labral tissue is all just cranky, not torn, but irritated because of the repetitive out the front, out the front, out the front. So what you do here is you go here, relax totally, right? So little ER, and my hand is on the back of her hip here, right on the bone, and I'm trying to pull her dynamically. So I'm pushing forward my left hand, pulling back with my right hand, and that is mimicking the same fulcrum mechanism of anterior apprehension. So if I did this and she had hip flexor, anterior groin pain, or she was like, ooh, like don't go anymore, I feel nervous about that apprehension, you'd be ruling somebody in for anterior-based instability symptoms. Make sense?
Will they have that posterior pain too?
They might, yeah. And I've only seen that, again, this is not a flex, I've only seen that in elite gymnasts and Olympians who are like ridiculously talented hypermobile. Like they're like way on the spectrum of crazy mobility, and that's why they make a living out of it. Yeah. Go on your stomach. Yeah, I know how to say that without sounding like an idiot. Other one you do, okay? So figure 4. Again, this is for someone who's hypermobile. Aaliyah's right in the middle. She's not super hypermobile. She's not super stiff. So the hypermobile person would like be able to really significantly like have no problem getting their foot to their leg here. So you put them in a figure 4, which think about the anatomy, right? ER in extension puts more stress on the anterior capsular already, right? This figure 4 position is how you stress the anterior capsule and labrum, right? I come in off the back of her femur and I push anterior medially to try to see if I slide the femoral head forward if I cause any symptoms. Okay, so I'm here and I'm pushing straight that way. You okay? Pain? Yeah, and I think it probably hurts on her not because of like mega instability, but because she's not super hypermobile, and I'm jamming her hip into a not comfortable position. So that would be the prone figure 4. Hop up for a sec. I'll show you in a minute. I'll show because I have no issues here. Right, I have plenty of motion this way, and if someone were to push on my hip that way, like I'm already on the table. So if I had symptoms and I was painful, somebody pushing more into an anterior glide would feel pretty terrible. Okay, so that's the second test you can do, and those are for anterior apprehension. Very rarely, but I'll show it, is you have someone who does have what we talked about, which is that lateral wall impingement with the inferior glide down that way. So I straddle so much that it pushes my femur down. So you'll lay on your side. Again, very rare. Cheerleader, gymnast, circus people, but hold the side, bend here, relax, put her in some ER abduction, and I push over pressure into that lateral wall impingement, and this would probably cause symptoms on the impinging side, but she might have some groin pain because I'm fulcruming and I'm essentially laying her like this, hitting the femoral neck and tipping this down this way, right? So again, very rare, but that is more inferior medial instability or apprehension, okay? All right, and then on your back, last one. Again, this is not as common, but just to cover all the 3 motions. Hip is the like sub-AIS impingement. So it's literally just, you're here, and you flex them all the way to end range, right? And it's not IR adduction this way, right? It's just straight up hip flexion. And if they feel as though they have symptoms, not in their groin, but like right under their AIIS, where the rectus femoris attaches, you can get subspine impingement of the femoral neck, anterior femoral neck on subspine from kicking really, really hard, like Rockette dancers, right? And what happens is essentially they do a straight leg raise kick, and it's such a long lever that it causes impingement of the AIIS when they kick really, really hard. That's different than medial adduction IR femoral neck on labrum. This is outside more abducted that way. So that kind of covers all 3 that would you have, which is the more extension, abduction, flexion.
How much flexion would they need to get to actually have that happen?
A ton. It's like 160 degrees. Yeah, and they oftentimes get that with momentum. Like they're like stepping back and swinging as hard as they can. It's like an aesthetic thing. And so yeah, oftentimes it's like the very, very end range of motion. But they don't have symptoms posteriorly because the hip is designed to flex so much that it's not an issue. And those people are typically dysplastic and don't really have an issue as well. All right, so let's take 5 minutes and do just those FAI tests, instability tests. We'll do contractile till 10 until I know. The hip flexor one I definitely do. Yeah.
How do you differentiate between that and like if someone has hip pain in the labrum?
Yeah, you do all the intra-articular tests first to rule out mechanical symptoms and stuff like that. And then if they have no intra-articular pathology, you start looking at extra-articular stuff.
You have both.
You would probably show both on an MRI and then also have a positive snapping hip test. Okay, let's roll. All right, this won't be extremely in-depth because most of the stuff, again, is like MMTs and stuff that most people are familiar with, but just to kind of separate into compartments, right? Anterior stuff, iliopsoas or peritendinitis, a really good way to do that is resisted hip flexion in the Thomas position because you put that hip flexor on stretch and then you kind of have them contract from that 0 position. So that's pretty useful. Same thing for rec fem tendinopathy. If you had somebody extend their hip into the Thomas test position and then kick out and they felt, high rec fem symptoms, pretty self-explanatory there. Hamstrings, right? Self-explanatory. See Mike Reynolds' blog post for a better explanation than me with Brooks. But you essentially put them into different positions and have them contract and see if they're getting symptoms proximal or distal at different angles, right? So you could argue that doing bent all the way up and then flexing somebody would be more proximal hamstring tendon versus getting somebody more in the knee extended position. The mid-belly starts to get stressed more, and then prone, right? Putting someone at 135, if they bend their knee, it's a lot of distal stress. And you could do tibial ER versus IR to see if somebody has more. So adductor pathology, I think the one that is only worth mentioning is the squeeze test at 0. So they lay on their back, you put their hands on the inside of their medial malleoli, and they just squeeze together. And the only reason I included that is because in a couple really good soccer studies, adductor pathology and not predictive, but correlated with future injuries was a decline in strength at 0 degrees. So max effort strength adduction went down. They later down in the season had some groin symptoms as well. So I tracked that just to see if somebody has heavy adduction pain. Inguinal stuff, cough, sit up, all that jazz. The one I did want to show is the glute med tendinopathy. So there's definitely a change in the literature that bursitis type stuff is not really shaking out to be as useful as we thought. Diagnostic injections, people don't get better, and also there's not a lot of thought process to that now. So glute med tendinopathy is thought to be more of the promising thing that might be going on with lateral hip pain, and there's 2 tests that can be used to do that. One is resisted ER so flex your hip up to 90 in ER and then have them contract into that motion more, because it wraps the tendon up around the greater troch and it can cause some symptoms. And then a lateral hip drop. So lateral hip drop is just standing here off a step and having someone do a glute med drop and kind of pull back up and back down, because as you adduct more, you get compression of the tendon over the greater troch, and that's usually very symptomatic in people when you get pressure. But Aaliyah, hop up and I'll show this one. So on your back, right? So you would have that person flex up, right? ER more, and then have them try to pull into ER. So try to do this motion that way. Yeah. So you're wrapping the greater troch right up around the tendon and then pulling, and you contract that muscle more when it's round up and compressed. It can be very symptomatic on the outside of the hip. So pull in, right, and you just do ER that way. Yeah. So that's been a really helpful test that I've done, along with the hip drop test, just standing and dropping up and down that way. You're good. Thanks. And then lateral stuff, also piriformis. I think we all kind of know the Patrick's test, laying on your side, just having someone drop across and just see if they have palpation this way, contract back against it. The ischiofemoral test is one that I didn't know. Ischiofemoral impingement is the lesser troch on the ischium when somebody walks. So if you walk really narrow, I guess, I've never really seen too many people with this, but if you walk in long stride narrows and like your hip crosses across, you sway this way, you can get impingement of the back of your butt on top of the is the lesser troch on the ischium. Yeah, so the lesser troch can hit on the way back. And I haven't seen that a ton, but if you have someone passively extend and adduct down, you can produce some of those symptoms as well. Piriformis, the other test that they do in the textbook is having someone sit like this and cross their body across and internally rotate, and then you can palpate the greater troch facets, right, and see if somebody has piriformis symptoms, similar type of split nerve pathology, they think. So a combination of Patrick's and then this kind of cross-body palpation, contraction of the glute med. Sometimes, I guess, I've never used that test a ton for piriformis, but it was in the textbook, so I figured I would include it. And then snapping hip, internal versus external. So internal is the TFL over the lesser troch or the hip flexor tendon as well. So the fan test is just doing what usually reproduces them, which is just essentially doing abduction and moving and circumduction around and seeing if they feel that popping, snapping when they move from flexion and they move in that way. And you can feel it pop back and forth over the tendon. Versus the hula hoop test, which I had to look up, which is pretty fun, which is literally just standing like this and going around back and forth and seeing if your IT band snaps over your greater troch. Yeah, that's a fun one. So yeah, a lot of these active-based stuff is kind of honestly common sense once you get through most of it. Are there any questions or tests that you want to see out of that list? Because I want to spend 15 minutes talking about treatment stuff. Make sense? Okay, and then neuromechanical stuff, the last layer, we would do that very early in the eval with toe touching and bend backing, but at repeated motions to see if somebody gets, obviously, symptoms, right? If they do repeated flexion and they start getting traveling groin pain and extension makes it better, you're thinking it's probably back, not hip. All right? Okay, so let's talk a little bit about treatment stuff. So biggest thing in the acute phase is honestly teaching the person about what the pathology is, and based off that, what things to avoid or what things to modify, okay? So when someone has, for example, you can look at this gentleman's surgery. He had 10 days ago, maybe. I saw him 5 days post-op, and he was doing great. So he had labral repair, femoral neck osteoplasty, so they shaved down his cam, and a capsular closure. And his x-rays were crazy because literally it's like this giant bump. And not only do they shave it down to neutral, they want to restore the contour, so it's actually this way. So he goes from this giant bump with a cam lesion all the way down to a concave contour of his femoral head. So it's a ton of bone they took down. And so for him, so I wanted to put this in because this is actually a pretty common protocol in terms of what they want to do. They always are very careful with the initial weight bearing for 2 weeks because the compression forces of walking put pressure through the labrum. Okay, so he's on just a 20-pound weight bearing, or just enough to get his foot flat on the ground so that he's not using his hip flexor to hold his leg up all the time and causing a hip flexor tendonitis. Crutches for 3 weeks. He did not have a microfracture, so he's not off of weight bearing. But the range of motion precautions are important to remember. So no extension past 0 for 3 weeks because they don't want to stress the anterior capsule. Not the anterolateral capsule they cut through for the portal holes, but also they don't want to stress the anterior labrum that's getting reconstructed, right? That extension motion can stress the front of the labrum. External rotation, avoiding extreme ER for 3 weeks because that also stresses the labrum and the anterior capsule. IR is no limitations, but it's a tolerance, right? You don't think that person has a cam anymore, which is pinching, but you obviously don't want to go jamming their hip into aggressive hip flexed IR. That's why log roll testing or log roll passive range of motion is pretty good. Abduction, they're usually just careful about that extreme range of motion. Flexion, 70 for 2 weeks, and then just don't aggressively push through impingement pain. 90 after that, just to be careful, and then just being cautious around anything that's end ranges. So those are his precautions now, right? And then on the next sheet, you can see his goals for 1 and 2, right? Not too groundbreaking, but less swelling, less pain, do the range of motion with his limits, and then he has a CPM at home he's using. We have not started the bike just yet because he was only comfortable to 70 to 90 degrees of hip flexion, and it's really hard to bike if you don't have 90 degrees of hip flexion around there, so we'll probably start that next week. And then trying to make sure that he's getting muscular recruitment back, right? So trying to find ways to exercise him, isometrics, contractions that don't involve flexing his hip up too far. And so on the third page, the last one is that dot chart, which again it comes with its challenges, one of which being is sometimes they will give you precautions of exercises or precautions of motion, but the exercises contradict those dots. So perfect example for him, it's no extension past 0 for 3 weeks, right? But if you look at his chart, it says start phase 2 exercises if no microfracture at week 2. The first exercise on the next phase is hip extensions. So the protocol says don't extend his hip for 3 weeks, and then the other side of the protocol says extend his hip at 2 weeks. And so you have to kind of be thinking in your mind about like what was the surgery, what was involved. Let's use common sense here, not just blindly follow dots. So I'm not going to have him do those things for 3 weeks because I'm nervous about that. All right. So I'll just show you exactly what I'm doing with him right now. Kevin, let's fake a hip surgery. Okay. First things first is I would not use this table because it is too high, right? He always gets priority on that table to put him down really low. So he's on his crutches. He sits down. Kev sits down on his crutches on the corner. It's this hip, so I make sure his leg's front. I grab his leg, and he shimmies on back this way. Right? I intentionally put this thing back so his hip is open, right? So I intentionally open him up this way, heat, and I let him sit for 5 minutes, and then he has shorts on, and we do all his soft tissue this way, and then we do all his soft tissue on his adductors, right? And I let him do all that stuff just to be comfortable. And then when we lay him down, I do not let them eccentrically lower themselves down or sit themselves up because they're using their hip flexor a ton. So usually what I'll do is I will either hold him like this, definitely Joe, is I give them my hand like this and I let them just fall into me this way. So lay all the way down so he's got nothing but his hip flexor. Okay, and when you're here, biggest things are passive range of motion is circumduction is very good to hydrate the hip joint. So I'm here, right? I'm doing them here, and I'm just doing passive, and scooch over a little bit, Kev, to the left. So I can get a little bit of circumduction motion is like the first bread and butter of like, it's not gonna hurt. Person's so nervous the first day post-op, and like just doing this is like, oh, it doesn't hurt at all. It feels fine. And they kind of relax a little bit, right? So circumduction, very, very important. And then the other one that Mike Voigt has a lot of is log rolling mobilizations, because if you IR and ER here, right, from like 20 to 20, there's no IR compression on the hip because the hip is open, right? And then slight ER is helpful this way as well because we're not wrapping capsules up. So I'll do a lot of log rolling IR, ER for passive range of motion as well. I do those two first because comfort level is really high, anxiety is really low. And then, of course, we want to range flexion, and someone's going to be a little more nervous, right? If you come and just blast flexion right away, it's not going to be a good start, okay? When we range somebody, right, again, slight abduction, a little bit of ER within his protocols, but just just acetabular plane flexion just to here. And I literally just went to like 45 to 60 degrees for the first day. We got him to 70 by the end of the session. But a combination of doing a little bit of range of motion first to warm them up, right? Trying to get them here. And then when I want to get hamstring and I want to get some adductor soft tissue stuff. So I'll have him shimmy this way. I support his leg and Kev roll to your stomach. And I kind of lift his leg and let him go all the way. Okay, they want to have somebody lie on their stomach, prone lying, to get them to 0 degrees of extension because they're always lifting their leg up into flexion. So you want to have someone's hip flexor contracture not be so stiff. So laying on your stomach for 15 minutes a day is really, really important. So I'll have someone just chill here and lie. We'll do adductor soft tissue stuff. We'll do all this kind of stuff. You can do some low back stuff if somebody is like hiking their hip, particularly if people have microfractures, they can't put their leg down and they're flexing their hip and on one side for like 2 months. So sometimes like low back soft tissue is really, really important there to do as well. So we'll do all that. That gives them 5 to 10 minutes on their stomach of hip opening, and then I'll grab their leg. We'll flip back over, buddy. Right, and so first couple days for him was just isometrics and baseline stuff. So it was just 10-second core squeeze, 10-second butt squeeze, 10-second quad flex, dig your heels in for 10 seconds, ankle pumps 10. 5 rounds of that was his first like initial exercise stuff going on. And he would just go through that just to get isometric out of the way. He said he could not feel his left butt at all, and he was having a tough time with that. So that was his whole first day, was CPM, me doing soft tissue, exercises, laser on his scars, make sure they look okay, ruling out red flags for DVTs, passive range of motion in the beginning, a bunch of exercises, another passive range of motion, another exercises, and then wrapped it up. That was it. And then just the other day, he started with just 45-degree bridging. So here, he can flex it up a little bit and I'll help him to get to here, not so much, but just doing glute bridges up and down, right? Just to get that 45 degrees, nice and easy. And then also we added quad rocking, right? Quad rocking is a really good way to start ranging the hip and closed chain. So fake that I help him turn back over, go on your stomach, right? Teach someone to, when you push up, I don't want a Mackenzie press up that sags the hip into extension. I want a piked intentional hip flex. So you have arm push up, nice flex to the hips. Start them here, walk your hands in a little bit, right? And so now I say quad rock back, make sure your knees are apart if he's not, right? But only go until your hips are not on top of your knees, because that's going to be about 70 to 80 degrees of flexion, so stop right there. And just quad rocking is how they like to regain motion early in surgery for hip flexion. It's much more patient driven. They're doing the work. It's not me jamming their hip up into flexion. So I'll try to do a little bit on their back to gain some motion, and then I say come back and only go until your hips are over your knees, which is 90 degrees. As we get farther in week 3, week 4, a little more abduction, a little more rock back to get to 120 or what else that is. He goes all the way back down, we flip back over. Yep. And that's honestly where he's at right now. That's like the whole first treatment for the first like 2 weeks. And then next week when he comes back, it's about weaning off crutches. So just getting him from 2 to 1, 1 to 0, that's really the biggest thing. And then you can see that at week 3 and 4, we start doing some pendulums on stomach, so just ER and IR on stomach. And then he'll progress down to doing more stuff, which is like open chain, right? Hamstring curls, hip extensions after 3 weeks when the 0 precautions are limited, and then standing stuff. We'll start doing weight shifting. We'll start doing some mini squats to 45. And then from 4 to 6 weeks, you just kind of go all the way through there. And then, yeah, man, that's it. That'll take them up to like 6 weeks. That's the acute phase. It's super boring, just respecting the precautions, but thanks, bud. Thanks. Any questions on that first week? Does anyone want to do any of the hands-on stuff, or are you good with all that? Fine. Cool. All right. So that's all I got. I think that's probably good for now. It's a ridiculous amount of information. I would say the best thing to do with it is to go through all the passive range of motion and special tests with somebody a couple times and make sure it feels good. And then once that feels good, go through some hands-on stuff like that. Like I think it is important to understand the ranging someone when they're very post-op and very, very acute, because the circumduction and the log rolling passive range of motion can go very crappy very quick, to be honest. Like if you don't know what's happening or what you're doing, you can definitely range someone in a weird position and it can bug them a ton. Or if you don't instruct somebody on how to do their range of motion at home, they're going to start doing rock backs with their knees close and really too far, and they're going to really crank up the front of their hip. They're very, very careful not to do direct hip flexor loading on most people, because either they move the hip flexor out of the way and they work on it a lot, or it gets so prone to a tendinitis because they're lifting their leg from the surgery with the crutches, that you really are careful with not loading the hip flexor at all for a while. And different surgeons have a thought process on don't ever load the hip flexor period, don't ever load the groin period, and I don't think that's a great idea, because they have to get back to sprinting and running in sports like Copenhagen's and stuff. But I think it's usually mid to late stages, like some marching, some Copenhagen stuff, some adductors. So once they're in the intermediate pass stage, that's when I would do that. But honestly, for the first like 6 to 12 weeks, I really am not doing any forward straight leg raises or worrying about hip flexion at all. They'll get it back normally. Yee. All right, that's it.
Steady.
No problem. It's up on the drive too.
I have a question.
Yes.
At what point in time, like, if someone comes into you and you're like the first point provider for like, and you're suspecting like a labral tear,
Yeah.
do you?
Okay, yeah, this is a great question. So this is exactly what happened with this gentleman that we're case studying. So if you look at the Warwick agreement, everything matched symptomatic labral tear. So he had symptoms mechanically, he had pain, he had limited motion, and he had imaging that he said he had the cam. He didn't know if he had a slap, but I was pretty sure he had a slap or a labral tear. So he had all the things that in my mind were like, this is going to be a tough go if we don't go surgery. And the first visit, I didn't come out the gates and be like, bro, you have a labral tear, you need surgery, right? Like, I even though all the testing suggested that, I was like, well, listen, this is what we do, right? We do all the testing. Here's the best possible scenario. He was at another facility. We're not going to talk about where or what, but he was just saying groin strain. It's just a groin strain. Keep stretching your groin. Just do it. They literally for 2 months were doing massage and groin strain management, and he just never got better. I was like, the best possible scenario is you have the worst groin strain of all time, and it's just really taking a long time. I was like, middle of the road. You have some of the bony changes and some irritation of the labrum, some irritation of the capsule. It's going to get better. Over time, you'll be okay. Worst case scenario, this cam is really causing a labral tear, and you have some problems. You have to get it dealt with surgery. So the course of action is usually conservative treatment, modify his lifting program. He got up out in the gym with Jonah, got a strength program that was more single leg based and didn't have deep squatting. Say we'll go 6 weeks of that. If you're no better at all, they'll probably do a diagnostic injection, which meets the Warwick's agreement anyways. And if they inject the joint and it gets better, you know that the labral tear is symptomatic. If they inject the joint and it doesn't get better at all, it's extra articular. So you go 6 weeks of that. So okay, if after 3 months of strength conditioning, workload modification, and an injection, you're literally no better and you can't run or sprint and you're still having pain, then you have that conversation about surgery. It took him about 2 weeks to get into rehab, and he was like, something's wrong here. And I was like, I didn't have the heart to tell him the first day, but I was like, bro, you probably need surgery. But I let him kind of slowly come to the realization that this isn't gonna go awesome. And again, he's a super high-level baseball kid with college and MLB prospects. If he was like a 15-year-old casual baseball player who's not going to play in college, I'd be like, don't even worry about it, man. Like, you're not going to do this the rest of your life. Like, just try to get by. But because he had such high aspirations, we're like, you want to get this taken care of now. You don't want it to affect your first year. You don't want to get there to school and try to hit, and then you have a huge problem and it blows out, and then you have to get surgery anyways. You missed your freshman year. So for him, it was like, here are the options. Best to worst. Here's the timeline of 6 weeks injection, 6 weeks, 3 months is failed conservative treatment, MRI, and then you would go forward. But he ended up getting it done, and you could see all the pictures kind of coming together, and he was like, I think I just want to get it done. And in my mind, it's going to take 6 months for really good rehab, and he has to go to school in August. I'm like, bro, let's just pull the trigger now. You have February to August to get better. And so that's where we're at.
So would you do like the same route if someone came in with no imaging and you were concerned about
Yeah.
articular pathology? Like you'd
I would.
try for 6 weeks, and then if it wasn't getting better, then you'd
Yep.
send for imaging.
Yep, exactly. I would do conservative treatment for 4 to 6 weeks to see if we could clear up mobility and or strength workload modification. And then if in 4 to 6 weeks he wasn't better, I'd send him to a surgeon we really trust to get the proper T3 heavy magnet imaging with the proper slices and see what they think osseous-wise. They'd take the alphas, the lateral side angle, all that kind of stuff. And if those matched, they'd probably do an injection then and then have him go another 6 weeks. And then if still not better, he'd probably get a surgical consult, and they usually do a CT scan where they see where the bony impingements are. Sometimes they'll do a dynamic CT scan where they actually have someone squat with dye in and see where contact points are made, and it maps out the topography of the osseous stuff they're going to shave off, how much they're going to take down on each side. So that'd be the last step before surgery. Yep. Word. Sounds good. Do you want it?